Good evening, everybody, and this symposium will treat about the laser and about what to do, and the main, it's what the subthreshold laser should be the treatment of choice for glaucoma patients. And it's me a great pleasure and an honor to have three speakers. The first is Mark Latina, and a great specialist of SLT, and then Peter Goves from UK, and then Nassima Benachi, who is working in my department in St. Joseph Hospital. And then we will share all the presentation about where to rank laser in glaucoma treatments. So Mark, I will let you as the first speakers about a clinically proven first-line treatment about SLT and selective laser trabeculoplasty. Thank you.
All right, thank you, Dr. Leskar, and welcome everyone to this symposium. I'd rather be in Amsterdam than here sitting in my office, and hopefully we'll get this to work. Again, my talk is on selective laser trabeculoplasty, a clinically proven first-line therapy. My disclosures: I am the inventor of SLT, also the inventor of this indexing lens with ocular instruments, and a speaker for Quantel. So as you all know, the philosophy of glaucoma surgery has been changing over the past several years, especially with the introduction of the MIGS procedure. I think our goal is now to intervene with surgery earlier in the disease process, reducing morbidity of progression, reduce the need for more aggressive surgical options while preserving that option, and reduce medication burden and the issues of compliance. So again, we're trying to use our surgical procedures earlier in the glaucoma treatment paradigm. The concept of SLT was developed back in the 90s when I was really asking the question, is it necessary to photocoagulate the trabecular meshwork in order to reduce IOP? And I wanted to develop a technique to target the trabecular meshwork cells selectively without causing any thermal damage to the surrounding cells or tissues. And to do that, we used a pulse laser to confine thermal energy to the tissues. The result was to produce a biological effect without coagulation. Sorry, hold on here. We found, and these are some histologic studies by Dr. Noacker and coworkers looking at organ cultured eyes, that there was no scarring of the trabecular meshwork with SLT compared with your ALT, MLT procedures, which produced coagulation and scarring of the trabecular meshwork shown here. With the advent of MIGS procedures, of course, and the use of the use of these procedures with canal surgery, I think the ALT is actually relatively contraindicated now, especially if you plan to perform some of these MIGS procedures. So using SLT as primary therapy, I think, again, think of SLT before starting prostaglandins. And I think our goal is really to simplify glaucoma management for our patients. We know medications have a lot of issues. They cause a lot of side effects, both local and as well as systemic side effects, conjunctival changes, pigmented red eyes, etc. But with SLT, you're really essentially 100% compliant. Now, actually, it was Melamed in 2003 that proposed SLT as first-line therapy, and he did one of the first studies showing that with the intraocular pressures in the range of about 26 millimeters of mercury, that he was able to achieve a 30% IOP reduction in these patients. And this was with an 18-month follow-up, and indicated that SLT was effective and safe as a primary treatment in these patients with open-angle glaucoma and ocular hypertension. Since then, there's been really a number of studies to confirm this. Nagar and co-workers did a study in 2005, Miguel with 2006, and then we did the SLT med study 2010 to 2011, which was a multi-center clinical trial. We looked at SLT again as primary therapy compared to latanoprost as primary therapy in eyes with open-angle glaucoma. We found that there was no statistically significant difference between SLT therapy and medical therapy, And actually, when we stepped the therapy, there were less steps with the SLT group than the medication group. We used a SIGIS protocol, so again, it was fairly well-controlled clinical trial, determining when to intervene and what target pressure had to be achieved. The McGilchrist study similarly showed similar IOP reductions in 90% responder rates comparable to latanoprost as primary therapy. Again, shown here with intraocular pressures, again in the mid-20s, showing about a 31% IOP reduction with SLT compared to 30.6 with latanoprost. Now, what we did notice is when we were performing SLT therapy and looking at the responder rates, that those patients on a prostaglandin actually did not seem to be do as well compared to those without a prostaglandin. So we actually looked at this, and there have been a number of studies since then looking at the effects of prostaglandin on SLT. But this is one study by Harasimowicz and coworkers, and they showed that eyes treated without prostaglandin showed statistically greater IOP reduction compared to eyes treated with prostaglandin prior to SLT. So our theory was that potentially SLT was acting much like a prostaglandin. And George Alvarado and coworkers looked at SLT's effect on Schlemm's canal cells in some very elegant studies, looking at conductivity of the cells, and found and looked at also the histology, and found that SLT and prostaglandins act similarly on the tight junctions of the Schlemm's canal cells, allowing changes in the tight junctions such that there was improvement in outflow. So again, SLT is an outflow treatment, and it basically can act as a prostaglandin. So more recently, of course, I think this has been the greatest contribution to our understanding and use of SLT in the clinical practice. This was, of course, the LIGHT study by Gus Gazard and coworkers, and the LIGHT trial group in Great Britain. Again, this study was designed to question a change in clinical practice pattern, and there really haven't been too many large-scale clinical studies that actually really affect a change in our clinical practice pattern. The hypothesis was that SLT as first-line therapy would be associated with better health-related quality of life, less need for meds, and lower cost. So the results is that, and I think this study has enlightened us, and I'm going to give you the results first, that SLT should be offered as first-line glaucoma treatment for open-angle glaucoma and ocular hypertension, supporting a change in clinical practice. And this is the study profile. They enrolled 16,000 patients, of course, a huge clinical trial, and randomized 718 of those patients to SLT versus medications. I think it's important to point out what the evidence was before this study, just to bring everybody up to speed, and what our sort of understanding was with SLT. Two meta-analyses were published in 2015, and they showed that 360 SLT showed similar IOP reductions compared to prostaglandin or monotherapy or combination, which is what our studies and previous studies found. Cost effectiveness was modeled and showed that it to be cost effective when compared to IOP lowering medications. The time threshold for which SLT became cost effective was approximated to be 1 to 3.3 years. And SLT was predicted to be cost effective when repeated at least once within 3 years, compared to those on monotherapy or multiple drug therapy. So the results of the study shown in this table here were that basically 95% of patients in the SLT group reached target compared to 93% in the eye drop group. There were more treatment escalations with eye drops compared to SLT. There was more progression during that trial with eye drops compared to SLT. There were more adverse events with eye drops compared to SLT. 11 patients required surgery to control the intraocular pressure compared to none with the SLT group. And basically, at 3 years, 74% of these patients remained drop-free, saving about 451 pounds per patient. So this was quite significant. and again suggested that SLT should be looked at more closely as primary therapy. Again, in summary, target IOP was maintained at more visits in the with the SLT group than the eye drop group. Actually, there was not significant changes in the quality of life indexes, except for the glaucoma symptom scale, which was slightly worse for the eye drop group in 5 out of 6 time points. And again, over 36 months, the result was that 97% probability of SLT as first-line therapy being more cost-effective than eye drops. And I think an important benefit from the patient's point of view was that SLT, having a drop-free window, was really an important aspect of having SLT therapy. This is just a brand new, just recently being published study, which now looks, and this is from the LIGHT study group as well, looking at visual field outcomes from this multi-center clinical trial. Again, they now looked at the visual field changes in the med group versus SLT, looking at point deviation rates. And their conclusion was that a greater proportion of them, of the pointwise pattern deviation rates, were categorized as moderate or fast in this medical in the medical group compared to the SLT group, basically concluding that a larger portion of glaucoma patients treated with medical therapy underwent more rapid visual field progression than those compared to SLT. This is actually similar to what was occurred in the GLT study, and that was a 7-year follow-up, where they also found that patients who underwent argon laser therapy back in the 80s with 7 years of follow-up had less visual field progression than those having medical therapy. Again, suggesting that SLT does preserve vision more long-term. So SLT, I think, is easy to perform. It can be done in the office. We usually use 100 spots or either superior or inferior 180 degrees, treating 45 to 50 spots. Again, there's no scarring of the trabecular meshwork. This is the indexing lens that I use in my office. I don't have time for a video at this, since it's short, but it's a very nice lens to use, and it's actually nice to teach the residents how to perform laser trabeculoplasty. Again, we are using the Pontel laser, which is an SLT YAG laser, and this has been very nice to use in our treatment. So basically, to go through this quickly, what we found again over the years is that 360 degrees of SLT treatment gives the best results for primary therapy compared to 180. Of course, we're treating according to the level of pigmentation. So we usually start about 0.7 millijoules. If the patients are more lightly pigmented, we would increase the pulse energy. If they're more darkly pigmented, we reduce it. We're looking for these intermittent cavitation bubbles, but you don't need bubbles for every spot. Postoperatively, the question has been whether to use steroids or not, topical NSAIDs or nothing. So this study, the SALT trial, sort of tried to look at this, and they examined whether the short-term use of nonsteroidals or steroid therapy affected the efficacy of SLT at 12 weeks. It's relatively, again, a short study. Again, they looked at NSAIDs versus saline, and this group of patients treated 180, 270, or 360 degrees. Their conclusion was that the short-term postoperative use of NSAID or steroid drops may improve IOP reduction after SLT. I use NSAIDs postoperatively. I use it the day of surgery and then the following day, morning and evening, so basically only for 2 days, and I find that this is adequate. What is the best predictor of success? It's still baseline intraocular pressure is best correlated with the percent IOP reduction. Shown in this table here is a combination of studies, but what we expect to see is that, most of our patients in the range of 22 to 20 or 30 millimeters of mercury, you'd expect to see intraocular pressure reductions in the range of 20 to 30%. Is it repeatable? I think yes, SLT has been repeatable, and there have been a number of studies to show that it's repeatable. My sort of point here is that if you have a successful SLT treatment the first time, you have a high probability of successful repeat treatment. And this was a study by Tony Reolini, again looking at 38 eyes. Success with at least minimum success at 6 months and show success after the first and SLT treatment. I think this study is actually even more interesting in that by Dr. Wells and co-workers, that the second SLT actually had a longer survival than the primary SLT treatment shown here. So again, I think as long as the SLT is effective initially, and usually with a efficacy of 6 months or a year, that you usually get a good response to SLT as a second treatment. So overall, there's a low complication rate, no systemic side effects. IOP spikes are usually small, 5% or so. There can be some mild postoperative iritis, which usually resolves with steroids. There have been these rare cases of corneal edema. We're not quite sure of the etiology. But there can be some persistent IOP spikes with pigmentary glaucoma, so you should use lower energies as fewer spots with the group of patients. So I think the evidence is in. The LIGHT study does support a change in clinical practice pattern. I think it shows that it can save us money. Patients are more compliant, obviously. It does show a greater percentage of IOP reduction than when the patients are on medications. I think it does give us the best option for long-term success. It does reduce, I think, has shown now to reduce the rate of glaucoma progression compared with medications, and is cost-effective and improves compliance. And again, our goal is to simplify glaucoma management. Thank you very much.
So thank you very much for this presentation. It's a